without further ado, we'll get started with our first interview that was done by my co-moderator, Eric Lund, with Dr. Swiontkowski. I just want to give a shout out to Eric Lund and the North Star Trauma Group up in Minneapolis, St. Paul, who are having an event tonight where they're all watching and logged in.
Thank you for giving me and the AO your time this morning to discuss your paper. I appreciate it. So I don't know if we just want to get into the kind of context of the late 80s and early 90s for distal femur fractures, and to what extent your practice was then, what your colleagues were doing, and the implants available.
Adult femur fractures were still being treated in traction. Acetabular fractures, for the most part, except for posterior walls, were being treated in traction. Shortly after I arrived, Dan told me that he had hired Roy as a fellow from New York, and I'd never met Roy. So we worked together, and there was really not a whole lot of essential difference in our experience, being both very young. So we did surgery together, and then Roy drifted over to the Nashville General, but still worked a lot at Vanderbilt. And Nashville General was way underserved, and he just did an excellent, outstanding job of fashioning a service over there, an orthopedic service. It had been not well staffed previous to that. The faculty learned a dynamic new technique of retrograde flexible nailing for distal femur fractures using Ender's nails. And then a guy named Zickel from New York had a device that had curves on it, a little more substantial than Ender's nails. It also had a locking screw. So they were using those devices for distal femur fractures, and were at least able to get people out of traction. So in the toolbox for the AO large fragment set, all you have is a 95-degree angle blade, which I had some experience with and had confidence with. But a lot of the fractures involved the articular surface to a much greater degree. So that forced us to learn how to use the condylar buttress plate, which of course is not angular stable. There's no locking devices, and so the first thing we figured out was that you should, when you have the distal block assembled and there's not a whole lot of comminution, what you can do is angle a screw through a more proximal plate at about 45 degrees to essentially push against the medial condyle and try to control the angle that way. And you could do that, and we actually subsequently published a biomechanics study out of Harborview to prove that it really does that. That only works if you've got a substantial medial block. So we figured you've got to do something to maintain the articular shaft angle. So we started putting medial plates on to do that, and we were using either T plates from the large fragment set, or we were using standard plates, because you don't really need too much other than one or two screws in the distal block and one or two in the shaft to control the angle. So, and then Roy convinced his mentor in New York to add cases. So Howard Rosen was a co-author on it, adding some of his. I don't remember who added what, and it worked pretty well. We learned pretty quick that the dissection on the medial side is important. You kind of have to peel the VMO off the intermuscular septum in order not to denervate it or damage it. So we learned that. And those medial plates bug patients. We learned that because they're fairly prominent, at the adductor tubercle. So a lot of them had to be removed. Lecturing on this earlier in my career, I have the case that inspired it. It's really a failure of a condylar buttress plate going into varus. And because a lot of these were C1 fracture types, you had partially threaded screws. So the interface between the holes in the plate and the screws was not rigid at all and could easily move. So that the failure is and of course the failure ultimately led to locking plates. I think that was one of the really early areas where the technical commission of the AO, which I had the pleasure of serving on for 5 years in the early 90s, we recognized this was one where you need to do something.
Also struck me about this case series was the high rate of success. So 9 out of 9 united. And these were, as you mentioned, high energy trauma patients. There are 5 open fractures that were, 4 of them were grade 2 and the rest were grade 3. Yet no non-unions, no infections.
You know, our soft tissue technique, because of our training, both Roy's and mine, was really pretty good. And the distal femur has a robust blood supply. So unless you really do too aggressive of dissection and the open injury isn't too severe, you're not very often going to get infection if you have stable fixation. And we had stable fixation to beat the band with dual plating. Also feel obligated to point out, you know, this was a cohort study. I can't honestly remember if we had cases that we didn't include in the series, but anytime you have a cohort series, that's a possibility. You have selection bias involved.
Fair enough. And then speak to the fact of bone grafting, open fractures, and acutely bone grafting just a closed distal femur fracture. Back then, you were doing that, and do you have any use of that now? And could you talk about that?
It was kind of the theory at the time that you needed bone grafting, and I would say it's not very often done any longer. It's something we learned from experience in metaphyseal regions. It is rarely needed, if any.
One thing that was noted was stiffness and range of motion.
Stiff knees. Yeah.
Even though you guys basically let him move right away, and you use CPM.
Yeah, we did, and I think it's because of that medial dissection. You know, to elevate the VMO certainly is not a benign thing, and you're really creating a bunch of scarring on the medial side of the knee. So I think that's the reason why they're relatively stiff. Later, I removed some of the plates and manipulated the knee, and it did increase, 20, 30 degrees of flexion.
Them is indications for single implant versus dual implant for distal femur fractures, and how you go about that in your practice.
Yeah, well, the implants are great now. It's really, really rare that you have to add a medial plate. And that usually has to do with very poor bone quality with a bad fracture pattern. Of course, we have better nails for retrograde nailing too, so that's an option for people with shorter metaphyseal fragments than we had when we were bending Kunstler nails. But the locking distal femoral plate, single plate, is pretty good. If I were to add a plate these days, I would probably consider going to a 3-5 plate, 3-5 implant as the strut, rather than what we were doing, which required much bigger dissection and more scarring.
Dr. Swiontkowski, thank you for spending your time with us to go over your clinical expertise and obviously research expertise on this paper and otherwise. The AO and the listeners, thank you for your time.
Well, I owe a lot to AO. Stefan Perrin helped me start my career, and it's been a pleasure to go back in history and think of those times when Roy and I were energetic and arrogant and never thinking we were wrong.